Hello, I'd like to share with you my presentation on what has changed my practice the most. And it has been decompression of peripheral nerves in patients with diabetic neuropathy who have superimposed nerve compressions. And that's a mouthful. You can go to Dellon.com and download chapter 2 from my pain solutions book to learn more about this. I'd like to start at the end, which is that neurolysis prevents ulceration and amputation in diabetics who have superimposed nerve compressions. Diabetics have many nerve compressions. As you know, we are all aware of upper extremity nerve compressions, such as carpal tunnel syndrome, but half the patients with neuropathy have positive TUNNE signs over lower extremity sites of nerve compressions. If we decompress these nerves in the lower extremity, we can expect the same results as in the upper extremity. Pain can be improved, sensation restored. In the lower extremity, if there's sensation restored, we can prevent ulceration and amputation, decreased admission to the hospitals. And this work now has become accepted worldwide. This is important because diabetics with neuropathy are increasing, and this trend is planned to continue in every country in the world. Many people have impaired glucose tolerance and are unaware of it. And this trend also is going to continue. When I finished plastic surgery training in 1978, this was what we expected: progressive and irreversible neuropathy with ulceration and amputation. There was no thought that surgery could prevent any of this or any of these costs. This is how I got started. As a young hand surgeon, I would decompress the carpal tunnel in one hand, and the patient would ask if I could do it in the other hand. And then in time, somebody asked me, since I made their hands better, could I help their feet? And I was really unaware of the symptoms of neuropathy. But as you look through them, you realize they're really the same as a patient who has carpal tunnel syndrome. And so the question was, if we could decompress the carpal tunnel, how would we decompress the tarsal tunnel? And we began work to identify the tunnels, and there are really four. There's a medial plantar tunnel, which is the same as the carpal tunnel. There's a lateral plantar tunnel, the same as Guillaume's canal, and they sit under the flexor hallucis, the same way the transverse carpal ligament would sit over the median nerve. And so we needed an operation that would open each of these tunnels and remove this septum. In time, through placement of catheters, we learned that these tunnels really do have increased pressure, besides having identified them anatomically. We found that people who had failed tarsal tunnel surgery had so because they had not had all of these tunnels decompressed. And then finally, in patients in the operating room, we could measure increased tarsal tunnel pressures in these patients as well. The operation that I designed was to open the tarsal tunnel, retract the abductor hallucis, identify the roof of the medial plantar tunnel, the lateral plantar tunnel, and also open the calcaneal tunnel and remove the septum that was in between these tunnels. Here's an example of the incision and opening so that we released, having identified the tibial nerve, the medial plantar, the lateral plantar with its calcaneal branch, then going distally, retracting the muscle and releasing the medial and lateral plantar nerves in these distal tunnels. And at the end of this surgery, you can place your finger from this area into the bottom of the foot. So the question was, the diabetic with foot symptoms, could this be tarsal tunnel syndrome, and would decompression help them? And this was the point we made in an editorial as early as 1988. Now, if you're a surgeon and you see this, you want to learn.
Has it been since you could feel your feet?
About a year.
About a year?
Yes.
Let's have your sister touch your right foot, which didn't have surgery yet. See if you can feel that much.
No, I can't feel that.
No. Now let's see what happens when she touches your other foot. You just had that surgery yesterday, right?
Yes.
What happens there?
Yes.
Okay.
Now everybody wants to learn how to do this surgery, unless of course you're a neurologist who thinks that this is completely confabulated. And it turns out that if you add the tibial nerve and the peroneal nerve, you can get a stocking distribution of sensory changes. And so the operation we designed for the peroneal nerve was an incision near the fibular neck. And I'll show you the fibrous structure that's present in just 20% of normals, but in almost everyone who comes to surgery. Many people need the deep peroneal nerve decompressed over the dorsum of the foot. And the superficial peroneal nerve is also compressed in some of these people. I want to show you a person who's not a diabetic, who's had a fractured fibula. And here is the common peroneal nerve, and it's compressed by this fibrous band. This is underneath the muscles in the anterior and the lateral compartment. And this has to be decompressed. And when it is decompressed, you will see the dent where the nerve has been seriously impaired against the underlying bone. And this is a diabetic. And this yellow area is not a lipoma, but in fact is the common peroneal nerve swollen. Here will be the fibrous band that will have to be divided after we retract the muscles. And you will see the indentation in the nerve that has been released. Why do the diabetics have so many compressions? The endoneurial tissues are swollen. This was shown as early as 1978. And the subperoneal edema is present and endoneurial edema. So the nerve is swollen in a compressed place. There's also decreased axoplasmic flow as postulated by Upton and McComas in 1973, shown by Jacobson and Sedinius in 1980. We demonstrated this in an experimental model in an animal that was not diabetic, and then we did show it in a diabetic model. There's also glycosylation of the type 4 collagen in the endoneurium, which creates stiffness of the peripheral nerve, again, rendering it susceptible to chronic compression. And our first paper in 1992 had upper and lower extremity patients, and you can see that 80% of these patients had good to excellent results. One patient was downgraded when I injured a branch to the foot everters as we were first learning to do that surgery. We can expect with this surgery a 7-year result in a diabetic with neuropathy with recovery of 2-point discrimination and prevention of ulcers and amputations. The patient must move immediately after surgery. They use a walker, and you can see this type of bandage that supports them. We then went to the animal laboratory to see whether or not we could understand this in a basic science model. And all of you, I think, are aware of walking track analysis, where you can measure print length and intermediate toe spread. And so giving the animal streptozotocin and following them for a year, we found that glucose goes up over a period of time. And when it does, the print length goes up. And in some of the animals with only one injection, they recover to a normal glucose level. Print length returns to its normal length. And so we had a good experimental model. We then, under the microscope, found the tibial nerve and could decompress the lateral and medial plantar nerves and the calcaneal nerve. And so we created 2 groups of animals, a group over here that had an intact tarsal tunnel and a group over here that had decompressions of their tarsal tunnel. And over a period of a year, the animals with blood sugars of 100 walked the same as animals that were not diabetic, whereas the neuropathic walking track pattern occurred in animals that had an intact tarsal tunnel. This basic science work has been confirmed by a group in Turkey. It's been identified and confirmed by Maria Simonow's group at the Cleveland Clinic, and it's been identified by a group in Romania. So where are we now besides at this meeting? In fact, there are many clinical studies now, both from the United States and internationally. I'd like to share with you this one, where a group of patients were operated on and only one side was operated on, and then they were followed. This side, which has had surgery, you'll notice has no amputations, where a side that has not had surgery 3 years later has both an ulceration and an amputation. An example from another patient where there was surgery, followed for 7 years, no ulcerations and amputations, but on the contralateral side, we see an ulceration and an amputation. I do not believe this is a placebo effect. And when the data is analyzed, we can see that there's a statistically significant difference in the fact that decompressing nerves in one leg prevents ulcerations and amputations, which in patients with the same blood sugar does not prevent them in the non-operated leg. And we had a series of 30 workshops where we trained 353 surgeons from 45 states and surgeons from 22 countries. Here's a prospective study, all surgeons using the same technique for surgery and outcome measures. It's presented to the American Diabetes Association 10 years ago. And we can see that with a large group of patients within 6 months, there's improvement in pain. Over a period of time, sensations recovered. We expect 1 out of 6 patients to have an ulceration. We found, in fact, that there was only 0.3% of patients over 3 years that had an ulceration. In patients who have had previous ulcerations and have been followed without close follow-up, however, we expect 70% to recur. In this Medicare-funded study where podiatrists followed the patients every 3 weeks, we still had 40% recovery, recurrence of ulceration. But in patients where they had sensation recovered, only 3.8% had a recurrence. Amputations can be expected in these group of patients, but if they've had the surgery, this is greatly reduced. Hospitalizations in a group of patients followed closely in the same Medicare study had 3.7% of the patients admitted to the hospital. In our study, only 0.6% were admitted to the hospital. Hopefully, this information can be translated to the community at large. Selecting the ideal patient will be someone with symptoms. Their glycemic control is good. They've not responded to neuropathic medication. They don't have swelling in their feet. They have good circulation, and they have a positive TUNNE sign. If someone has a positive TUNNE sign and is a diabetic with neuropathy, the positive TUNNE sign is a 92% positive predictive value. Coming down to the conclusion now, there has been meta-analysis carried out, and this meta-analysis demonstrated that in the studies that had been published and reviewed, there was an improvement in pain of greater than 3 points in 91% of the patients. Almost 70% had improved sensibility, and there was a significant reduction in ulcerations and amputations. This can be looked at in PubMed, and as of October 1st, 2024, we find that there are 160 patients. These included 14 retrospective studies and 3 meta-analysis, and all conclude that there's improved sensibility. We'd like to show you the 3 level 1 studies. One from Holland, the first one produced, had significant improvement in pain, which was the only outcome they looked at. Another one from Canada only looked at pain as an outcome, but had a significant relief of pain. We now have a study that's gone on for at least 4 years that was presented with significant improvement in pain, and this included sham surgical controls. The 10-year results of this surgery was just presented this past year at the American Association of Plastic Surgery meetings. There's a great economic cost-benefit analysis also. This can be done through simple decision tree analysis, but the preferred and most difficult method is a Markov model simulation. This was published in 2019, and I just would like to share this with you as our final slide. When compared with standard prevention in a population of 10,000 people observed over a 5-year period, 1,447 ulcers were prevented, 409 amputations were prevented. The incremental cost effectiveness was 0.41. You should know that a 1.0 is a perfectly healthy, normal, full life. A typical diabetic with neuropathy has already a 0.4 only for their quality of life. So we're doubling the quality of life in these diabetics. And survival's improved because without ulcerations and amputations, there's improved survival also. So in conclusion, in the United States today, there are about 10 million people with neuropathy and lower extremity nerve compressions. Decompression of lower extremity nerves is not harder or different than decompression of upper extremity nerves. The surgery is proven to be successful. There's a great economic cost effectiveness benefit to doing this surgery. I suggest you add this to your surgical practice. I wish to thank you very much for listening to this talk. And at the present time, we're going to stop sharing and end the talk. Thank you again very much.